So yeah, we just want to engage in the debate about what's required from the law from a medical perspective. And as Marion has outlined, if we take a patient-centred approach to that, there should be no different than asking, what do women need? And I'm going to finish with perhaps the more challenging question of what do women want? The notion that women who choose abortions are patients like any other, I mean, there's a sentence of great condescension, but we haven't got that. And I think it is extraordinary that in a way that is centrally what we are demanding. But the central components of that are consent. The consent should come from the patient. This is the most general principle, as Marion outlined it. And access to services, as Deirdre referred to. In order for that to be real, it's a lot of good to consent to something that you cannot then access. And as people talked about, even access to those medications, one of which, mifepristone, is not even licensed in Ireland currently. How even the PLDPA, with its 1%, less than 1% of abortions that it deals with, and the 99% that it doesn't, how it even operates without the proper medication. Nobody's even asking the question 2 years after the law was passed. Now, next slide. What we are saying is, that the only medical need is that the legislation does not get in the way of. Now, there is an argument for elements of the law that might be necessary in order that other elements of society or the state don't get in the way of good practice. Good practice not alone does not need to be regulated in the law. It is my argument generally that good medical practice should not be regulated in the law. There should be elements of the law that make sure that people have a right to question and call medicine to be accountable, but it should not be regulated in detail. And one of those details should not be procedures like abortion. For consent, all we need is the patient to consent, in this case, the pregnant woman. It shouldn't be a priest, it shouldn't be a doctor, it shouldn't be a judge. These should be ordinary, everyday things. But we constantly see the attempts to legislate that if it's not the woman who's going to make the decision as to whether or not she accesses an abortion, then who's it going to be? Which women do you want to say can't make the decision when you're legislating? And if you do say that, who is going to decide outside of that woman? Which panel of the great and good? The only real grounds for consent are that you have proper information, that you have capacity, and that you're not under duress. And I think the duress one is the argument against the criminal law having anything to do with your access to healthcare. Capacity is possibly the issue which most draws attention to the most sexist interpretation of the desire to legislate in this area, is that women simply do not have the capacity to make decisions about their own healthcare. And I think we can obviously throw that one out the window, I would hope. But again, any attempt to legislate that someone other than the patient consents involves either poor information, a suggestion that women lack capacity, or an inclination to introduce duress and coercion into the area of healthcare, which I think we should always resist. And finally, alongside consent must come access. And we have to be clear. If you're going to talk about certifying who should have an abortion, then you're certifying about who shouldn't. And we have to be clear, when you restrict access to abortion, you increase the incidence of disability and death. This is a little segment of a longer declaration. It's only about a page long. It's worth reading. You can Google it. It's on the internet, the London Declaration. And it's very clear about how we approach the legal frameworks. We're looking for autonomous decision making. Women should be the only ones who make the right decision for themselves. The reason we easily adopted that in Doctors for Choice is that's not just a pro-choice principle, that is a basic foundational medical principle which we should not, as doctors, break, and that's what we're bringing to the party as such. But it is a fundamental element. To say you're pro-choice means it must be women who decide. If there is to be pro-choice legislation, it cannot be allocating that to anybody else in any circumstances. Next slide. So, in terms of restricting consent, it's not pro-choice, it's not safe, it's not medical. In terms of restricting access leads to delay. Delay leads to more complications and to disability and death, at times to unsafe abortions. 50,000 women globally died in 2008, the year I have figures for, and 5 million women were disabled by a procedure that is incredibly safe. I mean, it has to be emphasized. Particularly early abortion and access to early abortion is an incredibly safe procedure. Those 50,000 deaths are not connected with the procedure. Those 50,000 deaths are due to criminal sanction and legal restrictions on access to abortion. Restrictions to abortion drive up suicide. We know this historically because the rate of suicide in pregnancy and the puerperium soon after birth has fallen dramatically on the introduction of abortion, and particularly the incidence of the suicide peaking in the 2nd and 3rd months show the connection with the realization of pregnancy and so on. And finally, on the restriction element, it does not reduce the number of abortions. Countries with high rates of restriction and criminalisation have high rates of abortion. So even that notion, oh, well, we have to because we need to restrict it and try to drive it down, it doesn't, it drives it up. A final word on late abortion before I look at the final slide. Late abortions, those are very rounded figures, but they're easy to remember and they're not far off the very correct, the more accurate ones, which vary from country to country. But just a notion of how 99% of abortion occurs before 20 weeks, 99.9% before 26 weeks, i.e. the second trimester as we talk about it. And these tend to fall when there are fewer restrictions. However, as I think Anne outlined earlier, and I think someone else mentioned it as well, there will always be a need for late abortion. If you're going to respect the consent of a patient, you're going to respect their consent in all circumstances. And I think that slogan we should all be ready to repeat. As early as possible, we want early access to early medical abortion. But as early as possible, as late as necessary. And my last one is who decides is not a technical medical question. Okay? Or it's not certainly one about which there is great controversy. It is the patient who should give consent. It's not a legal technical issue either. This is a political question which all of us don't let any doctor or any lawyer or any politician tell you well, leave that, we're going to go over here in a little committee and decide all these technical issues. Who decides and access to abortion services are political questions, and we can clarify today there is no medical basis for an exception to consent. There is no medical basis for certification or restriction for access. No medical basis. In fact, both of these things, in our view, are unsafe. It's a woman's right to choose. Repeal the 8th.